Hi, I'm Robert DeBernardo. I'm a GYN oncologist at the Cleveland Clinic. I run the section of GYN oncology, and I also hold the Laura J. Fogarty Endowed Chair in Uterine Cancer Research. Uterine cancer, we usually think of cancer of the endometrium or the lining of the uterus, but technically includes cancer of the uterine wall, which would be a muscle cancer like a sarcoma. And some people would include cervical cancer, which is the very lowest part of the uterus in that category. But for our discussion today, we'll limit it to just endometrial cancer because that tends to be the most common one that we think about, and clearly the most common cancer somebody like myself, a GYN oncologist, would deal with. Endometrial cancer is the most common gynecologic malignancy that we'll see in the developed world. It's probably 40 to 60,000 women a year in America will get that, and the incidence is actually climbing. In terms of risk factors for endometrial cancer, we start to see endometrial cancer around the age of 40, and then it increases throughout life. Most commonly, about 85% of people are going to be post-menopausal, so after the age of the menopause. Other things that contribute to that risk are obesity, high blood pressure, and diabetes. There are some rare genetic conditions like Lynch syndrome or a syndrome where you have colon cancer in your family that can also put you at an elevated risk. The most common symptom 90% of women will develop is abnormal vaginal bleeding. Since the majority of women have already gone through menopause, so they're not having menstrual periods, it's generally something that is easily recognized and people will seek attention to their physician. We start to see these cancers develop around the age of 40 and higher, so some women will still be having menstrual cycles. If they become irregular or heavier or change in any significant way, it's worth chatting with your doctor. It's very easy to make this diagnosis. It's done with a biopsy, which is a relatively painless procedure that can be done in most instances in the office, but occasionally women will have a D&C to make that diagnosis. We also typically will use an ultrasound to image to the uterus and the ovaries as well. For most women, a hysterectomy is curative, or certainly if not curative, the best place to start. Because if you think about it, the cancer is inside the lining of the uterus, and a hysterectomy is really just removing that uterus in its entirety. So if the cancer is inside that, we do a pretty good job of treating this cancer. And for most women, that's what they need. So we can, in select cases, treat this conservatively with hormonal therapy. That's successful 85%, if not more of the time, and it can allow women to complete their childbearing without having to have a hysterectomy. We can sometimes choose to treat women that are medically ill, that a hysterectomy would be a pretty risky endeavor, with either hormonal therapy or even radiation treatment. In rare cases, if we have widely metastatic disease, chemotherapy is generally the first place we start. There is a subset of these cancers that is very aggressive and can be life-threatening. However, those are the minority of these endometrial cancers. The vast majority of women I see with endometrial cancer are cured of their disease. Somewhere on the order of 85 to 95% of women are going to be cured. I think the garden variety endometrial cancer that we most commonly see, I would say the numbers are probably higher. Today in my practice, most of my patients go home the same day they have surgery. So I think most people leave the office feeling a lot better than when they came in. I think any of us being told we have cancer, all of a sudden it's lights out, what's going on? And hopefully when they're leaving my office, and hopefully when we're sitting down looking at that final report, they're breathing a pretty big sigh of relief.